Hello and welcome to the Oath and Staff podcast. I am A. David Singh, bringing you stories from people of medicine who serve humans and animals in unique and wonderful ways. In today's show, I'm talking to Dr. Rohit John. Rohit and I know each other since 1992 when we were batchmates at our medical college, CMC Vellore in South India. I remember him as a quiet, studious man with plenty of pluck and wit when he wanted to show his playful personality. During his life, Rohit's career choices did not follow a straight line. He faced ups and downs, reflected upon them, and made course corrections. Now, he provides first line medical care to patients as a general practitioner in the United Kingdom. It is a great privilege to have Rohit on today's episode, in which you will get a glimpse into his life as a general practitioner or GP and his thoughts about general practice in the UK. Welcome, Rohit. Welcome to Oath and Staff.
Hi, David. Thanks for inviting me on your podcast. Uh, can I just say that when you asked me to join the podcast, I was a bit surprised. My first thoughts were he's either struggling to get somebody to chat to, or he's probably got a false impression of what I've been up to in my life. But you did say that um, everybody has a story to tell. So, with the risk of this being your most tedious and most pedestrian of episodes, let's dive in.
Well, I'm going to add humility to the list of qualities that Rohit possesses. And yes, I did want to talk to you because I wanted your unique perspective into how general practice is done. So let's start at the beginning. What got you started in medicine and later in general practice? What are the stories behind how you made your career choices, especially your journey into general practice?
Yes, I mean, with regards to medicine, it's difficult to pinpoint a specific episode which might have got me into medicine. I mean, there are a few experiences that you have as a child which you feel probably nudged you into medicine. Um, I've got memories as a child of what we call an experience day that was organized by students at a local medical school. And I still have memories of going through the exhibition. There were picture images, dissected human cadavers, um, medicine boxes. So that was quite an intoxicating atmosphere. Also, we had a local pediatrician who functioned as our family doctor, our family GP. I can picture his clinic to this day. I remember sitting in his outpatient waiting room, his consulting room, his instruments. Um, he had an excellent bedside manner. So I suppose these little experiences often nudge you towards picking your career.
Well, it's very surprising. I was speaking to another Rohit, Dr. Rohit Amritanand, who's a spine surgeon. He was also kind enough to come on the podcast, and he told me how childhood memories and experiences influenced his choice to join medicine. So I won't say I'm very surprised, but it is very insightful to hear the same story from different people.
Yeah, I think it's a lesson. I think it's a lesson for us all because I think the effect that you can have on young minds is incredible, and we I think need to remember when we encounter younger people, and the potential to have a positive impact on their minds is immense.
That's so true. So, Rohit, what was your journey into general practice like?
Well, that's a long, tortuous route. I mean, essentially, I found getting postgraduate training in India extremely difficult, very challenging. And I think I moved to the UK on an impulse. Few years of surgical training in the UK then led me into general practice, mainly because I was looking for a bit of stability. That move probably raised some questions for me, um, questions that I suppose you might have some thoughts on, questions about the balance one needs to maintain between ambition and burnout, um, the balance between getting outside your comfort zone versus falling off the rails and your life unraveling, the balance between being safe and secure versus being bold and adventurous. So that I'm still trying to figure that out. I'm not sure I got that right. I must say that I listened to your last recording on your podcast and I absolutely enjoyed it. And I think you've touched on some of these aspects. Just wondering whether you had any thoughts on that.
Thank you for asking that, Rohit. And thank you for watching that video that you alluded to. So, in my case, I believe it was not to find a balance. In fact, I was satisfied with my intellectual accomplishments. I enjoyed being a neurosurgeon, the complexity and the pace that my professional life brought. However, since childhood, I have been a writer. And I had always put that at the back burner while I was going through my medical training and later as a neurosurgeon. When I was in my 40s, I felt the need to do something creative, go back to writing. I was at a juncture where I felt that being a neurosurgeon was not my only identity. Hence, I took up writing in a more serious manner. And over the last 10 years or so, I have published some books, and I'm quite happy with the way that my life has changed from a neurosurgeon to a writer. So now let's bring the focus back to you.
Okay.
Did you have a favorite teacher in medical college? And tell us the story how they influenced your medical career.
Yeah, I'm not sure I had a specific teacher who I looked up to. I mean, there were several. I mean, as you know yourself, we were blessed with an incredible number of very, very good lecturers and teachers. I suppose the one subject that seemed to make an impression, probably because it was one of the first subjects we encountered, was anatomy. And I still remember Dr. Mary Jacob. Very clear memories of her lectures and the way she conducted herself, both in the classroom and in the dissecting room. She's probably the one person who always comes to mind when I think about Velo.
Thank you for sharing that. Dr. Mary Jacob has had a profound influence on many of us. I remember talking to Dr. Sudhir Kumar, who's a neurologist in South India. When I asked him this question, he was kind enough to share his stories about Dr. Mary Jacob and how she had influenced his life and career. So, thank you for that, Rohit. Now, let's go a little deeper into what you're doing right now. What is the role of general practitioners like you under the wider umbrella of the National Health Service or NHS of the United Kingdom? Also, talk to us about the qualities that make for an effective GP.
Sure. I mean, to give a bit of background, the National Health Service was established in 1948, essentially to provide safe medical care to everyone in the country, including non-nationals who are living temporarily. And the idea behind that was to set up a service where patients' needs would be met um, based on their need rather than their ability to pay. I mean, the seeds for this kind of a service was sown in the early 1910s when there was a sort of a national insurance scheme, the scope of which was quite limited. In 1948, it extended to a much larger service. Um, the NHS essentially has three segments to it. You've got the hospital services, that's one. You've got community services, for example, people like midwives and health visitors, and you've got primary care, and that includes general practice, pharmacists. They are independent contractors to the NHS, so they work as small businesses, holding a contract with the NHS, providing services to the patients that are registered with them. Essentially, that's the structure of the NHS, and that's how general practice works in that system. We all in the UK expect, therefore, to be able to access healthcare whenever we need without paying a bill, um, which is obviously Times have changed. We're no longer in the 1940s. In the current world, with so much of advancement in therapeutics, diagnostics, it is proving to be a difficult service to sustain. What was your second question? Was it about the effectiveness of a GP?
Yeah, what makes for an effective GP?
I suppose you've got to look at what general practice is. Essentially, it's quite challenging and it's multifaceted. So you're never quite sure what walks through your door. So you could have somebody with chronic pain who's been to a pain clinic, who's still in considerable pain, who's looking for a solution. The next minute, you could have somebody who's quite frail and an older person with multiple morbidities. This could be followed up with an unwell child. You could then have somebody who's just come out of prison with complex physical, mental health needs, um, um, who's suicidal, somebody who's aggressive. On top of that, each consultation itself can be quite multifaceted. So it could go in a number of different directions. Very often, a patient might have multiple complaints. During a consultation, you might come to a realization that what's important to you as a clinician may not be important to the patient. So as a GP, you've got to be able to focus on two things. One, a potentially life-threatening problem, but also at the same time focus on what the patient perceives as a problem. And the two may not always be the same thing. In terms of what makes a good GP, I think essentially you have to be clinically very sound. Um, it might sound a little bit cliche, but it's important to be a good communicator, have very good active listening skills, which will just make you much more efficient. You've got to be able to enjoy people and have conversations. Now that seems like quite an obvious thing, but some of the conversations can be very challenging. And if you're not inclined that way, then you can find it mentally very exhausting to do this day in and day out. With regards to going back to basics, you've got to be able to avoid bias, both conscious and unconscious bias, when speaking to patients. For example, as someone said, don't go looking for something you believe is true, because you will find it. And that's very much the case with your clinical experience in general practice, where you often find that you might end up going down a blind alley or a rabbit hole and potentially miss something that might be quite significant. Patients can very often be quite poor storytellers. So they often come with an interpretation of what they think the problem is. So as a general practitioner, you might often find that you're sort of working as a detective. Patients can be very vague with their symptoms. You might have somebody coming in and just saying that they're just feeling a bit uneasy, or they can't quite explain what they're feeling. Or they might get some, I just feel a bit odd inside, doc. Can you help me with that? So it can be quite tricky. Um, as clinicians, we tend to like pattern recognition, and you often like neat categories of signs and symptoms, and you very often don't get that in general practice. The pyramid of health, at the bottom, you've got patients with lots of undifferentiated symptoms. So the skill set you need working with that group of patients is very different. For example, working higher up the pyramid, it's a completely different skill set. You need to be of a certain personality type as well to enjoy general practice. So you've got to be somebody who is okay with not getting quick gratification. For example, a surgeon. Um, the mentality is completely different from being in general practice. So yeah, I mean, there are certain traits and qualities that you need to work efficiently in general practice and be quite safe as a GP. As somebody once said that I was working with, you've got to be wise, you have to be kind, and you have to have the gift of discernment. That might sound a bit religious, but it's one of those qualities that will hold you good in general practice. Being a good GP involves working with other professionals in your practice. So modern general practice does look very different from what it looked like maybe 20, 30 years ago. Um, so just to give you a quick tour of what a GP practice would look like. As you walk in, obviously you see a front reception area where patients sit. You often have a front desk where you've got reception staff, and
Behind that, you often have something what we call as the back desk, which is often the nerve center of the practice, where you've got administrative staff taking calls from patients, etc. Um, you'll have the practice management team, which often involves a practice manager, an assistant practice manager, possibly a finance manager. As you go into the clinical rooms, you'll find GPs seeing patients with their chronic problems, or with patients who just called in on the day with acute problems. Um, you'd have nurses doing cervical smears, childhood immunizations, adult vaccinations. They'll probably be doing chronic disease reviews, COPD reviews, asthma reviews, diabetic reviews. In some rooms, you'll have pharmacists doing medication reviews, dealing with medication requests that patients send in, structured medication reviews, which are more enhanced medication reviews that they do with patients. You might find first contact physiotherapist seeing patients who are presenting with musculoskeletal problems. Mental health practitioner dealing obviously with patients with acute mental health issues. Practices these days very often might have somebody called as a social prescriber, who often takes referrals from other clinicians in the practice, mainly dealing with social issues that patients might have. At any particular time of the day, you'd probably come across meetings happening in the practice. There might be educational meetings. There'd probably be an MDT where you might have all the GP sitting in with health visitors and palliative nurses discussing patients on the cancer register. You might have teaching sessions for medical students, for trainees. Um, you'd probably have treatment rooms where you'd have procedures taking place. A surgery might be offering a minor surgery service. You might have joint injections. You might have contraceptive implants, coils, vasectomy services. Most practices would offer some or most or all of these services. You might have a pharmacy attached to the practice, which is often what we call as a dispensing practice. So they might have a chemist attached to them. Average size of a general practice now varies from place to place. It might vary anything from a registered list of 7,000 patients to about 30,000 patients or more. I think that's in essence what a practice might look like. Interestingly, some doctors have never walked into a GP surgery, especially some of our colleagues in secondary care. Especially some of our colleagues who've trained abroad, just like myself. They've probably never spent time in a general practice setting. Uh, so it might be news even to them.
Well, thank you for expanding our understanding of the complexity and the nuances involved in your profession, and the wide spectrum of patients who come to you both with medical and personal needs that you have to attend to. Now, I wanted to talk to you about an issue which has always puzzled me, and I feel that you are uniquely qualified to answer this question. As you know, both of us initially trained in India, where patients consult medical and surgical specialists directly without meeting a GP like you. However, the system in the UK and even here in Canada, where I live, is different. Patients have to first consult a GP or a family doctor who can either treat the patient on their own or decide to send them over to a specialist. Rohit, in your opinion, what are the advantages and disadvantages of a GP centered medical system like in the UK as compared to the system in India where patients can meet a specialist directly?
Sure. That's a difficult question, partly because I think in the modern world there is a risk that general practice there's a risk that it becomes less relevant because the world does tend to value a specialist opinion, and science and technology, I think, is also driving in that direction. Potentially, general practice might be in a position where it changes and it becomes more focused, meeting the needs of a few complex patients closer to their home. In the NHS, general practice was set up as being a gatekeeper to secondary services. And that was the idea behind setting up a general practice, where you had care quite close to a patient's home, where most of the patient's needs could be met without having to travel to a hospital to see a specialist. But I think the role has changed considerably over the last 50 years because of a number of reasons. You have situations where patients are very often discharged from hospital prematurely. So they often come out with certain unmet needs. I can think of an example where you could have, say, an elderly patient who goes in with dehydration and with kidney problems and a urinary infection, but comes out of hospital without the problems being completely resolved. And then it does fall to somebody else in the community to pick up the pieces. Um, you could have situations where patients are waiting for a hip replacement or specialist treatment or surgery. But while they're on the waiting list, complications can potentially increase. And then they've got to be able to access some service where they can go and address their problems. I always view health in terms of a pyramid, where at the top of the pyramid you have a few patients who need specialist care, but at the bottom of the pyramid you've got the majority of the public whose uh, problems can often be solved close to home in a primary care setting at a much cheaper rate.
Thank you for describing those issues rather succinctly. There's a lot that I'm learning today, which I had not really considered earlier. Now, when we were talking about getting you on the show, you had also mentioned that I might be part of a dying breed. Can you explain to our viewers and listeners what you mean by that?
I suppose there are two sides to that. I think it's probably the modern GP is probably going to be uh, is less likely to follow a tortuous route into general practice like I did. They'll probably be more streamlined in their training, where they'll probably do 5 years of medicine, 2 years of foundation training, which is mandatory, and then 3 years of specialty training as a general practitioner, which is 10 years of training. So I think for somebody like me who's had a tortuous route in general practice, it will be less common. And the other aspect is it's going to be less attractive as a career for the reasons I've just stated. There is a tendency, I think, in the current world towards a specialist opinion for most things, and therefore it will probably be less attractive for people to take up general practice as a career.
Rohit, what are the challenges that you face and rewards that you get as a general practitioner?
That's a good question. You have obviously an aging population with multiple comorbidities that need to be managed in primary care. You also have quite an unhealthy younger population presenting with problems that probably were unheard of a few years ago, like diabetes and cardiovascular disease. The other challenge in the UK is obviously politics might come into play here a little bit. Um, it has always been what people would call a political football, the NHS. A typical example would be a push towards getting patients access, but often capacity is something that's not is not dealt with. With general practice, you are very close to the community that you serve. So very often the rewards would be the sort of relationship you develop with patients and families, long-standing relationships. So very often you might see a young couple and you do a baby check for their 6-week-old. And then if you work in the practice long enough, you might see that child grow through the early years into their teens, and if you're lucky, you might see them as a young adult. So you often develop long-term relationships with families. The other thing is, I suppose you get to see an overall view of patient care. You have situations where patients are visiting various different specialists with multiple problems. Um, and when they come to you, there are different strands that you can see that you often need to bring together, and that can be quite rewarding. I mean, I've always thought of a GP as a broom being a good analogy, in the sense that you tend to sweep up a lot of problems and bring them all together. So I suppose there is a reward in that as well.
That's a very interesting insight, Rohit. Thank you.
Yeah,
If I ever plan to settle down in your part of the UK, I know who my GP is going to be.
absolutely. You're most welcome, David.
So tell us, we have spoken quite a bit about your professional life. Let's shift the gears. What activities do you do for leisure to balance your life as a GP?
Well, the early years were spent being a taxi service to the children. I've got two children, a son and a daughter, and a lot of the time was ferrying them to various different activities in school or after school. I played tennis when I was young, and I managed to keep up uh, playing for a few years. It's a bit on and off. So some years are better than others. Um, I do read when I can. There was a period of time where I'd stopped reading for maybe 5 6 years, but I've got back into the habit of reading, which is quite relaxing. I find I'm not as good as the wife because she can manage two or three books at the same time. I probably have to just read one, try and finish it, and then move on to the next. Um, I have two dogs, and I enjoy walking them. I think they've added a few years to my life. Yeah, so they keep me busy.
That is so true. Dogs are a wonderful gift from the universe.
Absolutely.
I feel they make us better human beings. Let's talk a little bit more about general practice. What's the one thing you'd like to change about how general practice is done or how general practice is taught?
Yeah, I suppose the one thing I would probably I would like to changing in the general practice might be um, the issue around consultation times that we provide to patients. We, unfortunately, in the UK are still on what we call the 10 or 15-minute consultation, which can prove quite difficult. We haven't increased it purely because of access, because when you provide more time, you reduce your access. So I would like to see that change. One of the things that I've experienced is the erosion of the trust and efficiency that you need between primary, secondary, and tertiary care. And there are various reasons for it. A lot of it have been inefficiencies in the system. So, for a state funded health system to function well, you need to have the efficiency between the different levels to run very, very smoothly. For example, referral pathways between primary and secondary care need to be much more simpler. Problems higher up in the pyramid can often trickle down. So one of the issues we've had in the UK has been reduction in the number of beds over the years, hospital beds. There has been an erosion of social care. The percentage of GDP that the country spends per patient comparing to other European countries is less. So certainly there are issues around funding, hospital beds, social care, and the problems higher in the system often trickle down and can cause stress and anxiety in the primary healthcare setting. That's probably one of the main things I'd like to see change over the next few years. One of the issues, again, is what you expect from your general practice or your GP offer you as the public. Um, it can become, as I said, it can become a bit of a political football. So, if, for example, the government expects general practice to provide high levels of access, you end up finding that the primary care might start functioning like an acute portal, like an emergency portal, a bit like the accident and emergency or casualty. What that leads to is obviously GPs and other professionals in the primary care setting, trying to meet that demand that's being put on them, and that takes the focus away from providing good quality primary care to the patients who most need it. The NHS is linked in quite closely with the political system. I'm not a politician, but there are some people who have suggested um, unlinking the NHS from the political cycle, like a cross-party committee that runs the National Health Service. I don't know whether that's practically feasible, but that's something that maybe needs to be looked into in the years ahead. Those are just some of the changes I would hope would happen in general practice that would improve the experience both for GPs and patients. In terms of general practice training, it comes back to the issue of the relevance of general practice. Obviously, over the last few years, we've had a lot of non-doctor roles, which do require a lot of supervision in general practice. And that can sometimes put a little bit of a strain on the GPs. Don't get me wrong, the non-doctor roles are very good, but I think if you expand them too much, it does become problematic. So I think a sensible conversation of how much of the non-doctor role is relevant.
Thank you for that, Rohit. What advice would you give to medical students who are considering becoming general practitioners?
I think it's important for them to keep their eyes open. to be aware of what general practice entails in terms of their day-to-day work. Certainly, they need to think about their personality type and whether it's something that would suit general practice. Have conversations with people, talk to colleagues, talk to GPs, make sure that's the right decision for them. I think it's probably also important for them to keep an eye out on the health environment and see what changes are at play. There might be a situation where there is a less requirement for a lot of GPs. It's something that need to be aware of, I think.
Do you get medical students who come and assist you in your clinic and thereby gain experience?
Yes, medical students in the UK do have an attachment in general practice, both in the third, fourth, and fifth years. So they have good exposure to general practice, and they are expected to start seeing patients as early as the fourth year. They do enjoy general practice because they get to sort of sit and examine the patient, come to a decision, and then have a discussion with the supervising GP. And they do enjoy that. They do enjoy that independence. So yes.
I guess that is quite different from the training we got as medical students. It was mainly a specialty based training rather
Yes.
than general practice based training.
Yeah, I mean, they do have their specialty training as well, but I think they make sure that there's a bit of exposure to general practice through the years. They don't spend an enormous amount of time. I think it's about between 4 to 8 weeks each year.
Rohit, it was wonderful talking to you. Many thanks for coming on the Oath and Staff podcast, sharing your thoughts about general practice in the UK, allowing us a peek into your life, and inspiring those who have tuned in.
Thank you, David. It's been a pleasure talking to you.
And that's all for today, folks. I hope you enjoyed this episode with Dr. Rohit John and also found it informative. Thanks for tuning in and subscribe for more.